Malaya, kebanggaan kita semua, pertama para ilmuwan di berbagai lapangan. Kami bertekad di hati mencapai cita bumi, tradisi kecemerlangan menepati wawasan. Di sini kami sedia berbakti, terus berinovasi. Kami harapkan generasi muda teras nusa dan bangsa. Masih kesayanganku, sungguh banyak jasamu membentuk insan mulia, berilmu berbudaya. Di sini kami sedia berbakti, terus berinovasi. Kami harapkan generasi muda teras nusa dan bangsa. Pasti kesayanganku, sungguh banyak jasamu membentuk insan mulia, berilmu berbudaya.
Please be seated. Thank you. Yang berbahagia, Dato' Profesor Dr. Awang Bugibah Awang Mahmud, Deputy Vice Chancellor Academic and International, Universiti of Malaya. Yang berbahagia, Dato' Profesor Dr. Adiba Kamaruzaman, Dean of the Faculty of Medicine, University of Malaya. Professor Dr. Maznah Dahlui, distinguished guests, professors, academicians, researchers, colleagues, ladies and gentlemen. Welcome to the inaugural lecture by Professor Dr. Maznah Dahlui, entitled Economic Evaluation for Health Advocacy and Informed Policy. Without further ado, I would like to invite Dato' Professor Dr. Awang Bugibah Awang Mahmud, who will chair today's inaugural lecture and introduce Professor Dr. Maznah Dahlui. Please welcome.
Assalamualaikum warahmatullahi wabarakatuh. And a very good Prof. Adiba, the Dean of Faculty of Medicine, Prof. Maznah Dahlui, who is going to deliver her inaugural lecture. Now, I've had the pleasure of chairing quite a number of inaugural lectures throughout my term as DVC for Academic and International. But I think none gives me more pleasure than to introduce and chair an inaugural lecture from a friend and colleague from my own department. Now, Prof. Maznah Dahlui is a public health medicine specialist who has worked for several years within the Ministry of Health. In fact, don't let her looks fool you, but we have known each other for quite some time now. I used to joke that wherever I serve, she seemed to follow me a few years after that. Prof. Maznah served for many years with the Ministry of Health and was an entrepreneur before becoming an academic here in UM in 2003. Her specialty is health economics, with a major interest in the evaluation of health programs. In the number of years that she has been a health economist, she conducted many economic evaluations of the country's policies and programs, working with various ministries in Malaysia, such as the Ministry of Health, Ministry of Labour, and the Prime Minister's Department. She has extensive linkages with the international institutions such as the UNFPA, UNESCO, World Bank, WHO, and these have led to several consultancy projects centered on the evaluation and monitoring of health programs. Prof. Maznah's research interest extends to cancer screening as well as infectious diseases such as HIV and hepatitis C, adolescent health and obesity prevention. I probably could use with a bit of that prevention myself. Applying what is known as the economic evaluation approach. She has been actively engaging NGOs such as the Breast Cancer Welfare Society and MAGNA, as well as communities, urban poor, and the rural populations, for breast cancer screening, as well as combating chronic diseases such as hypertension and diabetes. Her international research experiences include working with collaborators from the Sanger Institute, University of Cambridge in the UK, on the salt reduction study, the Kirby Institute, University of New South Wales, Australia, on the return of investment of the harm reduction program, the University of Usmanu Danfodia in Sokoto, Nigeria, on sexual reproductive health issues under the auspices of the Africa-Asia Development University Network, and many, many others. Professor Maznah was appointed as the Regional Director of APAC, which stands for the Asia Pacific Academic Consortium for Public Health, in 2013. I think she was one of those who was instrumental in bringing the APAC Secretariat from the University of Hawaii through the University of Malaya, where it still remains to this day. She used this as an avenue to initiate research collaborations on community obesity prevention with several of the 87 APAC member institutions. So that was why in 2012, the APAC Secretariat was transferred here to UM, and where she has remained as the secretary of that secretariat until now. Her appointment as the chair for the National Clearinghouse for Adolescent Health in Malaysia, as well as the chair of the Technical Advisory Committee of Health Technology Economic Evaluation, or TECTE, in Malaysia, are acknowledgements of her expertise and close working relationship with the Ministry of Health. Her outstanding contributions to public health in such a short span of time contributed significantly to her election by distinction as a Fellow of the Public Health Medicine Specialist Association in Malaysia, and also by distinction as a Fellow of the Faculty of Public Health of the Royal College of Physicians in the UK. Prof. Maznah's leadership capabilities has been acknowledged by the university with her appointment as the head of department from 2011 to 2016, and as a deputy dean in the Faculty of Medicine since 2016. She remains the Senate representative from the faculty from 2016 onwards, and sits in the Associate Professor Promotion Panel and Curriculum Review Committee of UM. It is therefore my singular pleasure in inviting Professor Maznah Dahlui to deliver her inaugural lecture entitled Economic Evaluation for Health Advocacy and Informed Policy. Please welcome Prof. Maznah.
Thank you, Dr. Professor Dr. Awan Bugiba, for kindly introduce me and for chairing this session. Yang berbahagia, Datuk Profesor Dr. Adiba Kamal Zaman, Dean Fakulti of Medicine, Deputy Deans, Profesor Datuk Dr. Yang Farida, Profesor Datuk Christopher Boyd, and Professor Yvonne. Dr. Sanjay Rampal, my head of department, my beloved friends, Datuk Farooq Harul Anwar, VC of MASA, Tuan Safura Jaafar from IMU, Datuk Prof. Dr. Reklas Rampal from UPM, Prof. Raja Latifah, friends, my beloved students, and my colleagues from SPM. Thank you for coming to this inaugural lecture, and I welcome you. Okay, these are the list of contents for my presentation today. But don't worry, I'm not going to give you a full lecture on economic evaluation, but rather I'm going to give you a brief presentation of video slides, which I hope will facilitate you to appreciate economic evaluation, because I'm going to share with you the many economic evaluation studies that I've conducted. And of course, I think, as has been mentioned by Professor Dr. Awan Bukiba, I will share with you my experiences with regards to networking, which have brought me where I am today.
What is economic evaluation? Economic evaluation is to determine which health intervention among several interventions with the same goal is most cost-effective. There are various public health interventions which can lead to healthy living, such as to promote health, to prevent disease, for early detection of disease, and to prevent complications of disease. All these activities need resources, but because resources are scarce, especially with limited budget, we have to make decisions which one to choose. In health setting, making the right decision is very important and should be based on sound evidence. Economic evaluation is designed to inform care providers and patients about the best available intervention. For example, to combat the issue of increasing prevalence of obesity, there are various programs that could be taken up, such as promoting physical activity or health education on healthy diet. Both would be able to reach the goal. So which one would you invest in? How do you do economic evaluation? First, you measure the impact of the programs, then calculate the cost, and finally perform cost-effectiveness analysis to look for the most cost-effective program. Now let us look at each step. What is health impact? It is the outcome of the interventions such as the incidence of diseases, survival, and quality of life. All the interventions will have the same outcome, but the level measured would be different for each program. It is important to know the cost of interventions and its consequences. It starts with the identification of the type and assessing the quantity of resources used before the value is imputed. Cost-effectiveness analysis is a full economic evaluation which looks at the health impact and cost of interventions simultaneously. The formula incremental cost-effective ratio is used to determine the difference in impact and cost when switching from existing program to a new program. Findings from CEA can inform us the value of money of interventions, assist in decision making, and for allocation of resources. So, did you understand? Now, Let us look at the examples of economic evaluation studies that I have conducted.
So actually, I've been teaching master in public health students for 9 hours on economic evaluation, and of that I've compiled it just into 3 minutes presentation. So I hope you can appreciate economic evaluation. All right, as you know, there are many health programs that need evaluation on their effectiveness, so that the decision whether to continue, to add, or to change to another program could be made. So I will now share with you the economic evaluation studies that I've conducted either with my students or with my colleagues. And you may see their names and more information from the publications that I will share with you later. So now with regards to antenatal care program, I'm sure Tuan Safura is very happy that I'm presenting about antenatal care program. So the antenatal care program has long been implemented, and I think it's time for us to do economic evaluation since some common indicators are rather stagnant for many decades. Therefore, a study had been conducted to determine the adequacy of antenatal care and its associated factors and pregnancy outcomes among women who attend antenatal care at public health facilities. What we did was in Selangor, but all the public health facilities in Selangor was included. Nevertheless, we think that the findings could be generalized to the whole Malaysia because of the setting of Ministry of Health is more or less similar in districts. So in this study, we had employed a retrospective cohort study design where data was extracted for individual records of public health clinics. Here, what we meant by adequacy of antenatal care is adequacy of utilization as well as adequacy of contents, and these both were analyzed separately. This was actually a PhD thesis by Yeo Ping Ling from Mediconsult Company. So what we found, with regards to the adequacy of care and pregnancy outcome for the different risk group, the low-risk pregnancies had a higher antenatal content score than the high-risk pregnancies. So it contradicts. By right, it should be more of the pregnancy outcomes should be in favor of the antenatal care among those with high pregnancies. So we reckon that the disproportionate utilization of the level of pregnancy indicates that there is a need for us to have a better scheduling of care, and these findings has been published in PLOS ONE, so those who needs to read further, you may refer to this paper. And with regards to the adequacy of content, we noticed or we observed that women, less than 80% of women had less than 80% of recommended antenatal care content that were documented. And the lowest score was actually found with regards to health education. Only 35% of the people who had antenatal content were on education. And it's also associated, the adequate content was significantly associated with the lower odds of preterm birth than inadequate content. Again, we had published this, and we reckon that all pregnant women should be given the complete scope of routine antenatal care, regardless of their risk level. There are more publications come out from this study, which you can read by just Googling the name Yeo Ping Ling. Okay, now with regards to obesity prevention, there are many policies that have been developed and adopted to combat obesity and non-communicable disease in general. However, the effectiveness of the planned health intervention would not be possible if the implementation is not carried out accordingly. So, in relation to this, a study had been done to determine the availability and to assess the level of implementation of policies for prevention of obesity among children in Malaysia. And this was a dissertation by Ms. Kamalina Chan. We found that there are many policies on obesity prevention, especially among school children. So in other words, the policies are adequate, but the implementation needs improvement, especially by the school administrators and by the canteen operators. And there were many barriers to policy implementation, especially on physical activity. And what we found was pertaining to lack of equipment, insufficient training, as well as lack of time for physical activity that is allowed by the school. An identified challenge pertaining to a healthy diet include the high cost of food that needs to be sold and the many preferences of the children. No matter how healthy the diet you prepare for them, they're still looking for chicken nugget. We also had a projected disease burden for hepatitis C, because this is another form of economic evaluation study pertaining to looking at the disease burden before we can apply the cost effectiveness analysis. So the estimation of hepatitis C virus infection is needed to perform economic evaluation to determine the cost of direct acting antiviral drugs for price negotiation, because DAA is not available in Malaysia, at least until last 2 weeks. Whether it should be licensed or is it worth it for the Ministry of Health to invest in purchasing the drugs for public hospital. So we had applied a multi-parameter evidence synthesis whereby we had used both the direct and indirect epidemiological parameters of interest. Although this paper, this study, the first part of the study was not a part of, this study was actually a part of the study that is ongoing by Dr. Amira Azari, where we now are looking at cost effectiveness analysis of introducing DAA among hepatitis C patients in our country. Don't seem to be fine. Okay, so let us look at the result. So approximately 454,000 persons were estimated to be living with hepatitis C virus infection, but this was in 2009. Okay, and although the majority of the hepatitis C virus infections occur in injecting drug users, the non-injecting group, risk group still represents a large proportion of the hepatitis C virus antibody positive population. The current treatment practice is also estimated to prevent cumulative total of 2,300 deaths from decompensated liver cirrhosis or from hepatocellular carcinoma. And the cumulative total of 63,900 hepatitis C virus-related deaths is projected to be avoided in 2039. So the manuscript has been published, and like I said just now, this is an ongoing study which is still not complete. We have already calculated the cost of treatment for hepatitis C and for possible intervention with DAA, and now we are coming up with the analysis of cost effectiveness. Similarly, the changes in the quality of life of transfusion-dependent thalassemia patients with or without iron chelated dextroamphetamine had to be established before conducting CEA to justify for the provision of dextroamphetamine at the public hospital. I did this study as part of my PhD thesis in 2003, which is quite ages ago. And we found that the quality of life of transfusion-dependent thalassemia patients on dextroamphetamine was higher due to less incidence of iron overload complications, such as there is hassle from pain because of injecting dextroamphetamine. So now I've already explained to you about the effectiveness studies. So now let us go to the cost study. So cost findings are very useful for accountability, for assessing efficiency, to consider cost recovery, ascertaining universal health coverage as part of cost effectiveness analysis and in planning for healthcare reform. I have to tell you that getting cost data is very challenging, not only because of poor documentation and inappropriate accounting, but also because of issue of confidentiality as well as sensitivity. Nevertheless, a costing analysis had been performed at Universiti Malaya Medical Center. Of course, I have to start at UMMC in 2012 in order to determine the cost per diem at the various wards, the daycare, and for the outpatient visit. These cost findings had been applied in economic evaluation studies on treatment and screening of many diseases, such as in determining the cost of treatment for upper gastrointestinal adverse events in rheumatoid patients, to determine the cost effectiveness of universal HLA-B15-2 as a screening method to identify patients prone to develop carbamazepine-induced Stevens-Johnson syndrome, and to see whether it would be cost-effective to test for BRCA mutation in breast cancer patients compared to routine clinical surveillance. The findings from these studies were recently published. Now, with regards to the cost of PCI, an elaborated cost study was performed to determine the cost and the cost predictors of patients undergoing percutaneous coronary intervention at various cardiac centers in Malaysia. The primary data collection on the individual PCIs was conducted at UMMC, at IJN, at Penang, Queen Elizabeth II Hospital, and Sarawak Public Hospital. So it covers almost every region of Malaysia. For the cost analysis, we had applied a micro-costing and step-down approach, while clinical data was extracted from the National Cardiac Registry. So what we found was, from the government side, it provides evidence on cost effectiveness of PCIs and how prioritization and of budget and allocation of personnel could be made. So this was published in BMJ Open and was referred to by the DG of Health in deciding on how much to allocate budget for IJN to conduct the PCI. So apparently, they have decided that most of the PCI should be conducted by the cardiac centers in the general hospitals, while IJN is given the more complicated procedures. You know, these are all important to maintain an equitable basis for financing health services in the face of escalating healthcare costs. Whereas, for the participating cardiac centers, the comparative analysis of clinical and cost management shows the areas of improvement that are necessary to improve efficiency of service provision. The cost results could also be used to perform economic evaluation on other cardiac interventions, such as to compare PCI with antiarrhythmic drugs or with radioablation frequency procedures, of which various or several officers in TACT or from MAHTA is conducting the studies for Dato' Omar, who is the cardiac head of cardiac in Malaysia, and I guess the study will be published soon, so do look out for it. And with regards to cost of dengue vector control, we had examined variations in dengue vector control costs and resource consumption between the district health departments and local authorities in order to assist decision-making as to the future roles of these agencies in delivery of dengue vector control services in Malaysia. So overall, district health departments spend about $679 per case, and local authorities spend about $499 per case. And as expected, the highest expenditure for both agencies was for fogging. So the findings provide some evidence to rationalize delivery of dengue vector control services in Malaysia. This was the RPH thesis by Dr. P. Ravi Varman, and the co-supervisor is Professor Dr. Ng Chi Wan, as well as a collaborator from UK. The first full economic evaluation conducted was in 2003 as my PhD thesis to determine whether it would be more cost effective for MOH to subsidize the Fluoxamine. This is a continuation of the earlier study on the effectiveness. And the findings showed that it was very highly cost effective to treat transfusion-dependent thalassemia patients on the Fluoxamine. Because although the drug is expensive, the quality of life, like I've shown earlier, was higher among the transfusion-dependent thalassemia patients on the Fluoxamine compared to none, and that the cost to treat complications of iron overload was much higher than the cost to treat transfusion-dependent thalassemia patients with the Fluoxamine. And this is all because of the less number of complications. Ministry of Health had considered these findings to justify in getting the drug listed, and since then Fluoxamine is available for free at all government hospitals. This is a study that I am very proud of because it really has policy implications. There are also another study that has assisted in decision making. In 2012, Ministry of Health has initiated an organized cervical screening program whereby all women aged 20 years old and above were invited for pap smear and received recall to repeat the test. And this practice was actually similar to what had been done in Australia and in United Kingdom National Health Service. Thus, a CAA was conducted to compare the various modes of calling women to come for pap smear between normal letter, registered letter, sending message via SMS. There was no WhatsApp then, and talk to them via telephone call. And we found that the woman would respond better if we talk to them personally. This was actually a DRPH thesis by Dr. Rima Marhayu. She's now in the Ministry of Health under the Economic Evaluation Division. Okay, next is with regards to harm reduction program. Okay, the importance of health research utilization in policy making and of understanding the mechanism involved is actually increasingly recognized. And harm reduction program is one of the programs that needs evaluation because it used to have aids from WHO and many other or even World Bank, but after some time they decided that they want to pull out the donation, and therefore we have to find our own means of money or budget for us to continue with the program. And as you know that the harm reduction program in Malaysia consists of a needle syringe exchange program and methadone replacement therapy for injecting drug users. The program was initiated in 2006, and after 2 decades, we thought that economic evaluation is warranted. So what we found was, although a longer time is needed for us to see the return of investment, it is actually cost effective from the perspective of the government because it costs direct saving in healthcare costs as well as because of the reduction in the infections. And this was a consultancy from World Bank to the Cheeria team, which I was fortunate to be invited as one of the investigators, together with the investigators from Australia. This can be seen in the World Report, in the World Bank report. You can Google in the internet and you can read this if you wish to. Another cost-effective analysis that we've conducted that was used for policy decision was on rotavirus vaccination. But mind you, this was not conducted in Malaysia. It was conducted by somebody else. For Malaysia, what we did was for Libya, because my PhD students was from Libya. In Libya, the burden of rotavirus infection causing diarrhea among children was very high, almost 40%. And economic evaluation was warranted to justify getting aids from WHO since a big investment on vaccine was needed. There were 2 publications on it. In fact, there were 5 publications on this, but what I'm showing to you are the one on the effectiveness as well as on the cost effectiveness analysis. And we found that the ICER showed rotavirus vaccination would be highly cost effective intervention to reduce the incidence of rotavirus infections. And also, again, it cost savings from less treatment and less hospitalization. And I guess this can be also applied in Malaysia. So this has made the government decided to provide vaccines for free to all children below 5 in Libya, even without aids from the WHO. Dr. Salim Al-Koshi now is working with CDC in Tripoli, Libya. With regards to breast cancer screening, several studies had been conducted locally on the KAP, or knowledge, attitude and practice of screening for breast cancer among women in Malaysia. But we need to know whether the current practice is still relevant or there is a need to change. Thus, we have conducted the studies and we observed that breast self-examination as screening for breast cancer and clinical breast examination are still relevant in Malaysia, where resources are limited. Although it was suggested by the Shanghai study that it is no longer relevant, but my study showed that in our setting, breast cancer screening by breast self-examination and by clinical breast examination is still relevant. And I have published this, and this article has been cited by many. So this is one of the articles that had contributed to my H index. Okay. However, there's still a question on whether we should follow the practice of mammogram as a community screening for breast cancer as in developed countries. And in order for us to know or to answer this question, we have to conduct economic evaluation. That is the CEA study. So an economic evaluation had been conducted to determine the cost of various breast cancer screening types in Malaysia, and whether or not to show whether or not it's worth for Ministry of Health to provide mammogram as a community screening for breast cancer in Malaysia. And we found that mammogram as a community breast cancer screening is not cost effective. While the current practice of CBE followed by mammogram if abnormality is detected, and mammogram of women with risk factors are cost effective according to the threshold set by MATA. MATA is a bit stingy because the threshold set is only 1 GDP. If you follow the WHO, it's actually 3 GDP. GDP means gross per capita income. Okay, it is recommended that efforts should be focused on improving the participation rate for CBE and increasing the budget allocation for mammogram for women with breast abnormality and risk factors of breast cancer. I'm very fortunate to have the opportunity to supervise my students, from whom I am very proud of. And together we had succeeded in completing the research and published in high-standing journals. But of course, the completion of their thesis was because of their hard work and their perseverance. Therefore, I would like to acknowledge all my students, including those who I had not mentioned in this inaugural lecture. And I'm looking forward for the graduation of students whom I am currently supervising. I'm not sure how many of my students are here, but I guess they are now watching the YouTube because I forced them to watch it. Okay, academicians or researchers should always aim to collaborate with other institutions like the government agencies, including NGOs, to work together towards the health of the community. Most of my breast cancer research were via my collaborations with Ministry of Health and Breast Cancer Welfare Association, and thus I would like to acknowledge them in this presentation. And my reputation as a public health specialist at international level is credited to my association with Asia Pacific Academic Consortium of Public Health, or APAC. I have been an EC member of APAC since 2012, from a secretary role to regional director, and now as one of the vice presidents. There are many important activities that were brought out brought into UM from this network, such as the double degree MPH Kyoto UM, and student exchange from Wuhan University of China, University of Mahidol, University of Southern California, US, besides several research collaborations by my colleague with the member institutions. And my international collaborations are very fruitful, whereby other than research, I had jointly supervised students with Kyoto University and University of East Anglia Ruskin, United Kingdom, co-author in many publications with international researchers, invited to deliver lecture at Taipei Medical University, University of Erlangen, University of Southern California, and I had gained tremendous experiences as visiting professors to University of East Anglia Ruskin and University of Erlangen. The long-term sound relationship with Ministry of Health and the works that I have done with them had led to my appointments as leaders of several national committees. Ministry of Health had appointed me as the chair, National Adolescents Clearinghouse Center with the Secretariat at UM, and as the chair of Technical Committee for Economic Evaluation Studies under MATA. I'm very thankful to all who had worked with me or those who had trusted me to conduct research, training, and consultancies. And I'm very thankful to the Almighty on the recognitions that I receive as academician, either locally or internationally, through the various appointments that were awarded to me. The appointments enabled me to promote health in the region and as far as to the African continent. Without any doubt, people around me played a significant role in shaping and directing my path into becoming what I am today. Therefore, I would like to take this opportunity to forward my appreciation by acknowledging the various people who had been kind and supported me, making my career journey smooth and happy. First of all, FOM management team led by the Dean, Prof. Datuk Dr. Adiba Kamaruzaman, who has inspired me in many ways, Prof. Tan Sri Amin Jalaluddin, and Prof. Datuk Dr. Khairul Anwar, both who had encouraged me, Prof. Datuk Dr. Aun Bugiba, who made me believe in my capability and pushed me forward until where I am today. And of course, my colleagues and friends from SPM, whom I have cherished very much. The environment in SPM has been very motivating and very happy. Of course, I look sad. I'm actually happy. I will never forget my mentors. The late Prof. Atia Abdul Salam, who had convinced me that I can succeed in public health. The late Prof. Autaching and the late Prof. Walter Patrick, who had brought me to APEC. Both had made me feel special with their compliments on my achievement. My ex-supervisor, Prof. Dr. Sheikh Muhammad Al-Junaid, who had made me interested in health economics. Prof. Dr. Reklas Rampal, a public health specialist that I highly respect. And last but not least, my appreciation goes to my family, especially my husband, Prof. Dr. Muhammad Amir Abbas, who had given me all the support that I need. His motivation has been instrumental to my career growth and success. And to my children, for being delighted with my achievement and for sharing the hard time in the journey of pursuing my career. I'd like to end my presentation with a pantun. Berjalan-jalan ke bukit tinggi untuk mencari pepohon ara. Bukan hamba meninggi diri, sekadar berkongsi kisah gembira. With that, I thank you. Assalamualaikum warahmatullahi wabarakatuh. Where do I go?
It's my great pleasure to call upon Dr. Professor Awang Bugiba back again to the stage to summarize and conclude today's inaugural lecture.
Thank you very much, Noran. Friends, colleagues, I see quite a number of familiar faces in the audience. Couldn't really see anybody from here because of this blinding light. Very sorry, I can't quite see your faces. But Prof. Rekraj Rampal, whom I've known for many years, I think, and of course, colleagues from the Ministry of Health who have come, Faculty of Dentistry, and so on. Now, I was wondering when thinking of how to summarize a lecture, anytime that I'm given an inaugural lecture, because most of the time I have no idea of the content, and I'm not an expert in the content anyway. But anyway, I'll try my best. In a previous life, I was the DVC for Research and Innovation. I'm coming to the end of my term as DVC for Academic and International. And a number of years ago, we started something called the Grand Challenge Approach for research. We wanted to go beyond publications. We wanted to see how far our own research would actually make an impact on society and the community and the country. And I was thinking, looking at your YouTube video, my first thought was, now why the hell did I think of a YouTube video for my own inaugural lecture last time? So you have outdone me in that particular respect. Secondly, I was thinking how right you are, that policies alone are not enough. We are awash with policies. We have so many policies. It's our implementation which is the problem. We have policies on aging, we have policies on obesity. God knows I've sat through so many committees and so on. But despite not being a health economist, I can appreciate a number of things that Prof. Maznah here has delivered to us today. Firstly, healthcare in Malaysia now is at a crossroads as far as healthcare financing is concerned. I used to joke that in the days that I was in the IKU, we have gone through God knows how many Director Generals of Health without settling this problem of healthcare financing. Is that right, Prof. Rampal? We have gone through so many, and I can name all these Director Generals of Health, but we still haven't tackled this problem of healthcare financing. But without healthcare financing, proper healthcare financing, where are we going to be as a nation? Some of our healthcare indicators are stagnant, as you rightly pointed out, and we will not get better until we devote proper resources to it. Now, devoting proper resources to this requires evaluation, and it requires really good economic evaluation for us to be able to make the decision whether to continue this program, start up a new program, or perhaps think of alternative ways of making our health indicators better than they are before. Now, the most gratifying feeling as a researcher, and I'm sure from Maznah, you will share, probably you will agree with me if I can rightly read from your inaugural lecture, is when our own research results in a policy change so profound and so impactful that it is taken by the Director General of Health. So with your inaugural lecture, where several of your own research projects have resulted in this policy change, have resulted in people rethinking on what they want to do for healthcare in Malaysia, is testament to your own ability as a researcher. So with that, I must congratulate you, and let us join me in congratulating Prof. Maznah Dahlui on this most impactful lecture.
Thank you, Dr. Professor Al-Mughibah, for chairing the lecture and for the conclusion of today's inaugural lecture. Thank you, Professor Dr. Maznah, for your wonderful and insightful presentation. It was indeed an inspiring lecture, especially to all of us who wish to make a difference in the world of research and ensuring that all our research are actually being translated into clinical and public health practice. I think that's what really matters most. And to end our session today, I would like to invite a representative from the family to come to the stage and present Prof. Maznah with a beautiful gift. Yeah, this is kind of a surprise, so it's...
Your daughter.
And this is going to be followed by a bouquet of flowers from the Julia Center, University of Malaya. So I would also like to invite the founding head, Professor Dr. Awang Bugiba, to also present a beautiful gift to Professor. And last but not least, I would like to invite the head of Department of Social and Preventive Medicine, Professor Sanjay Rampal, to also present Prof. Maznah with a very beautiful bouquet of flowers. Thank you all. Ladies and gentlemen, that marks the end of our event today, and I hope all of you have greatly benefited from today's inaugural lecture. And on behalf of the University of Malaya, I would like to take this opportunity to thank the management of the Faculty of Medicine, staff, students, distinguished guests, and everyone who have made the time to be part of today's inaugural lecture. I would also like to invite all guests for some refreshments provided at the Center Point and Gallery. And ladies and gentlemen, once again, our deepest gratitude for your presence, and have a great evening. Thank you very much.
Trust in your spirit. Yes, that's exactly what I'm talking about.